Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 445 of our pharmacotherapy series, which majors in prostate cancer. The next case reads, KPA has been recently diagnosed with prostate cancer after a biopsy. The results revealed a Gleason 4+3 which is equal to 7 in 5 of 12 cores. He discusses his options for definitive local treatment with the medical oncologist, radiation oncologist, and urologist. He decides to undergo radiation, and the radiation oncologist plans to treat him with EBRT in conjunction with 6 months of ADT. So my questions to you read: what side effects from treatment can KPA expect? What concerns will the medical oncologist have regarding side effects and his history, that is, past medical history, medication history, family history, and social history? Erectile dysfunction is the most commonly seen sexual adverse effect of radiation, but can include decreased volume of ejaculate, absence of ejaculate, decreased intensity of orgasm, and decreased libido. Erectile dysfunction 3 or more years after EBRT occurs in 36% to 68% of patients, and 50% to 60% of men have some extent of erectile dysfunction with brachytherapy. With radical prostatectomy, erectile dysfunction is seen soon after surgery but may improve over time. This is the opposite of what is seen with radiation, where it is more of a slow decline. In one study, 80% of patients receiving radiation therapy responded well to sildenafil. It was seen that 74% of patients in another study continued to respond after 4 years. Additional factors that may contribute to erectile dysfunction should be considered, such as coronary artery disease and diabetes, as well as patient age. Some patients will not respond and should be referred to a urologist or sexual health expert to evaluate other options for treatment. Next we will discuss external beam radiation therapy. Radiation treatment for definitive local treatment is typically 4 to 6 weeks long, with acute symptoms usually occurring around the 3rd week and resolving within days to weeks after completion of treatment. Symptoms such as diarrhea can be treated with standard agents, e.g., loperamide, diphenoxylate, atropine. Internal or external hemorrhoids can become inflamed, and Seats baths and hydrocortisone suppositories can help alleviate symptoms. Also, acute urinary symptoms may occur with agents such as phenoxyperidine and alpha blockers such as tamsulosin providing benefit. Late rectal toxicities from radiation therapy can occur 12 to 18 months after completion of EBRT and persist for several years, although developing adverse effects after 5 years is rare. These adverse effects can include rectal bleeding, mucus discharge, and mild incontinence of stool. Rectal bleeding can be controlled with increased fiber in the diet, steroid suppositories, and sitz baths, with rectal ulcers and fistulas occurring in less than 1% of patients. Late urinary toxicities consist of chronic urethritis in 10% to 15% of patients and urethral strictures in 2% to 3%. We will now progress to brachytherapy. Brachytherapy allows for the radiation of small areas of the prostate, which decreases some of the adverse effects of EBRT. In low-dose brachytherapy, acute urinary retention is known to occur in 6% to 15%, although better identification of risk factors for its development have decreased the incidence to approximately 6% in recent years. Transient urinary effects that occur include radiation-induced urethritis or prostatitis, urinary frequency, urgency, and dysuria. Symptoms will peak about 1 to 3 months after brachytherapy is placed and gradually resolve over the subsequent couple of months. Alpha blockers such as tamsulosin help relieve some of these symptoms. Patient KPA may experience some of the common symptoms from EBRT, which include diarrhea and hemorrhoids. Other urinary and rectal symptoms include rectal urgency, increased urinary and bowel frequency, and erectile dysfunction may also occur. The most common adverse effects include loss of libido, erectile dysfunction, hot flashes, weight gain, and muscle loss. Because patient KPA already has hypercholesterolemia and suffers from depression, which can be impacted by the use of ADT, KPA's medical oncologist must closely monitor for changes in these comorbidities and be proactive about treating them if needed. The next case reads, ZAG is a 42-year-old, African-American male who has come to his doctor's office to discuss potential ways to decrease his risk of prostate cancer. His father was diagnosed with prostate cancer at the age of 49, and his brother has just been diagnosed at the age of 45. Beyond lifestyle and diet modifications, what should ZAG's physician discuss with him about the use of 5-alpha reductase inhibitors? Because of the large number of men who develop prostate cancer, interest has turned to the possibility of prevention. There are modifiable risk factors that can be addressed, but there is also interest in the potential of drugs or supplements that can at least lower the risk or possibly prevent the occurrence of prostate cancer. The largest trials to date have involved the 5-alpha reductase inhibitors, finasteride and dutasteride. Finasteride is a competitive inhibitor of type 2 5-alpha reductase that blocks the conversion of testosterone to dihydrotestosterone in prostatic cells. In the prostate cancer prevention trial, abbreviated as PCPT, over 18,000 men aged 55 or older were included if they had a baseline prostate-specific antigen of equal to or less than 3 and a normal digital rectal exam. They were randomized to finasteride 5 mg daily or placebo and had annual digital rectal exams and prostate-specific antigen measurements. At 7 years follow-up, a 24.8% reduction in the prevalence of prostate cancer was seen for those men on finasteride. In the finasteride cohort, there were 803 cancers of the 4,368 men. The placebo cohort had 1,147 cancers in 4,692 men. There were more reports of sexual side effects, but were less likely to have lower urinary tract symptoms, which can be attributed to finasterade's mechanism of action and its use for BPH. However, for those men on finasteride, there was a higher proportion of cancers considered to be high-grade, Gleason score of 7 or more, with 280 high-grade tumors diagnosed in the finasteride group and 237 on placebo. There was concern that these cancers would be more aggressive. The risk was considered too high and few considered its use for prevention. At 18 years from the start of the trial, a post-hoc analysis of survival was assessed again to see whether there was an increased risk of death in the finasteride group because of the higher-grade cancers diagnosed. The 10-year survival rates in men with low-grade cancers was 83% with finasteride and 80.9% in placebo group, with a p-value equal to 0.46. And in high-grade cancers survival was 73% in the finasteride group versus 73.6% in placebo group. Updated data at 15 years found that prostate cancer had been diagnosed in 10.5% versus 14.9% of finasteride and placebo patients, respectively, with a p-value less than 0.001. In the finasteride cohort, 3.5% were found to be high-grade and 3% were high-grade in the placebo arm, with a p-value equal to 0.05. At 15 years, the survival was 78% in the finasteride arm and 78.2% in the placebo arm. The hazard ratio for death in the finasteride arm was 1.02. with a p-value equal to 0.46. The difference in the risk of death was not significant between the two groups. Overall, finasteride reduced the risk of prostate cancer by about one-third. Dutasteride, a type 1 and 2,5-alpha reductase inhibitor, was studied in a 4-year randomized, double-blind, placebo-controlled trial in which men were given either dutasteride 0.5 mg daily or placebo. These men were between the ages of 50 and 75 with a prostate-specific antigen between 2.5 and 10 nanograms per milliliter and one negative prostate biopsy within 6 months. There were 6,729 men who participated and cancer was found in 659 of 3,305 men in the dutasteride arm and 858 of 3,424 men diagnosed in the placebo arm. This was a relative risk reduction of 22.8% over the 4-year period, with a p-value less than 0.001. The difference between those with a high-grade tumor was not significant between the two groups. Erectile dysfunction was seen in 9% and 5.7% of men in the dutasteride and placebo arms, respectively, with a p-value less than 0.001. Decreased libido was also seen, that is 3.3% versus 1.6%, although the symptoms of benign prostatic hyperplasia were less in the dutasteride group. Less than 5% of men discontinued the study drug because of drug-related adverse events. The SELECT trial assessed the use of selenium and vitamin E in the prevention of prostate cancer. Research has indicated that reactive oxygen species may be associated with the onset and progression of various malignancies, including prostate cancer. This was a Phase 3, randomized, double-blind, placebo-controlled trial to assess the efficacy of selenium 200 mcg daily and vitamin E 400 international units daily, either alone or in combination. Over 35,000 men were included in this study who had a normal digital rectal exam and a prostate-specific antigen level less than 4 nanograms per milliliter. At a median of 5.46 years, no difference was seen among the groups. Patient ZAG's physician should explain that the 5-alpha reductase inhibitors did show a significant decrease in the incidence of prostate cancer, but that it is still not clear what impact they have on prostate cancer survival and may have a negative impact on the incidence of high-grade cancers. In addition, there are side effects that patients may experience with these medications, such as erectile dysfunction and decreased libido. Let's briefly consider survivorship. Because of the large numbers of prostate cancer diagnoses as well as the generally slow growth of the tumor, there are a large number of men who are living with or after a diagnosis of prostate cancer. They account for about 20% of all cancer survivors. It is recognized that physical and psychosocial effects can occur long after treatment is complete. The American Cancer Society created guidelines, last updated in 2014 and endorsed by ASCO in 2015, for the primary care physician to monitor the health of prostate cancer survivors. Quality of life should be assessed at baseline and monitored at least annually using one of the validated surveys for this purpose, 5-item sexual health inventory for men or International Index of Erectile Function. These are beneficial for identifying side effect burden or other adverse effects that are of concern to the patient. And now we will progress to healthy lifestyle. Guidelines include an emphasis on reminding patients of the benefit of achieving and maintaining a healthy weight, getting enough physical exercise, and eating a diet that is high in fruits, vegetables, and whole grains. For those patients with residual bowel problems that impact absorption, they should be referred to a registered dietitian. Guidelines also include cautions on avoiding alcohol or limiting it to no more than 2 drinks a day, as well as tobacco use and offering cessation counseling if necessary. Smoking increases the chance of recurrence as well as second cancers. Obesity is associated with increased prostate cancer-specific mortality and biochemical recurrence. Body mass index and healthy food choices along with physical activity should be addressed and encouraged by the primary care physician. Physical activity has been shown to improve cancer-specific and overall survival, help speed up recovery from short-term effects of therapy, and prevent some long-term effects. Exercise can improve fatigue, anxiety, depressive symptoms, self-esteem, happiness, and quality of life. Patients should be encouraged to engage in at least 150 minutes of physical activity per week. Finally, we will look at surveillance. Once treatment is complete, the prostate-specific antigen should be monitored every 6 to 12 months for the first 5 years and then monitored annually. An annual digital rectal exam is also appropriate, especially as some patients will not have a prostate-specific antigen elevation in the setting of cancer. As well, those patients who have received pelvic radiation are at an increased risk of bladder and colorectal cancers. They should have routine screening, and any signs of hematuria and rectal bleeding or pain should be referred back to their treating radiation oncologist for evaluation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 446.